I'll be discussing on the BP aspect of heart failure. Heart failure with reduced ejection fraction on treatment, asymptomatic but alarming with a BP of 90-60. Contemporary management of heart failure has improved survival, hospitalization rates and quality of life. And the major limitation they see in implementation of this GDMT is low BP. Around 66% of surveyors found that it is identified as a primary, and 31% showed that it is a secondary concern for starting or up-titrating the medicine. And this affects both the initiation, up-titration and also long-term maintenance of the medicines that have been started. I will discuss a case of heart failure and then go into the discussion. A patient, 56 male, old, anti-OLMI, LVF 28%, severe LV dysfunction on dual antiplatelets, sacubitril valsartan, beta blocker, dapagliflozin, SGLT2 inhibitor, MRA, eplerenone. These are the four. The second to fourth is the four pillars of the GDMT. Alongside, patient needs diuretic for decongestion, that is torsemide twice daily, on nitrates for angina relief, and also on tamsulosin for prostate hypertrophy. Patient is currently asymptomatic, heart rate controlled 64, BP 90-60, there is no edema, saturations are maintained, perfusions are maintained, creatinine is normal, and patient's HB is 11. What should we do for this patient? The patient is asymptomatic, 90-60. We do not need to modify any medications for this patient. 90-60 in a patient who is asymptomatic is on GDMT needs to be continued. And the point that we need to remember is a patient with a BP of 90-60, no symptoms, on optimal GDMT has better outcomes than a patient with a BP of 110-60 of HFrEF not on optimal GDMT. The survival is always better for better GDMT. Now coming to the BP, low BP and HFrEF, around 5% have heart failure reduced ejection fraction patients have low BP, and the incidence of low BP increases as the severity of heart failure increases. And as this low BP increases, there is also increased risk. It is a SBP less than 80 has a 2.5 fold, and a SBP less than 100 has a 1.5 fold increase in events compared to a patient of heart failure with reduced ejection fraction with an SBP of 120. So it means that we have to focus on these patients more. These are the patients who have higher risk, and these are the patients for whom we can reduce the risk more with the GDMT. There can be various other causes, cardiovascular and non-cardiovascular related causes, that causes low BP in patients on GDMT with heart failure. I would like to focus on some causes, especially the cardiovascular, especially the blood volume status, the valve disease, any other bradycardia that has been induced, other indications requiring BP lowering medications, maybe nitrates or for angina. Also, non-cardiovascular causes like iron deficiency, use of dopamine antagonists, PDE5 inhibitors, or intake of alcohol, also even intraocular beta blockers for glaucoma. There are other causes, but these are some things that can be easily modified by us. In addition, most of our heart failure treatments can affect BP, especially our ARNI. It is the most important drug, but it is the most hypertensive drug. In the paradigm heart failure, there are 16% asymptomatic hypertensive patients and 11% symptomatic patients with hypertension. But in the study itself, they showed that all categories of BP had improvement in survival and other outcomes with ARNI, irrespective of whether symptomatic or symptomatic hypertensive or normotensive. And also on the continuation of treatment, they found the trend that the BP increased by about 6 millimeters mercury on average on all groups. Even in the low BP group, without stopping ARNI, the BP improved. In this case, that I discuss what can be done if patient develops symptoms. One thing, we can assess fluid status, reduce the dose of diuretic, reduce the doses of other non-essential affecting BP drugs. For example, this patient is on nitrates, change to a non-nitrate anti-anginal drug, and maybe change to another drug other than alpha blocker for the bladder outlet obstruction. Other options to be done, that is modifying the GDMT only after these measures, that is reduce the dose of ARNI to half, see whether it improves. If the patient has high dose of beta blocker, reduce the dose of beta blocker. If the heart rate target is lost, add ivabradine for the heart rate target, and continue with the lower dose of beta blocker. Correct iron deficiency if present. C for severe MR. If MR, give MR, send for a surgical or mitral clip procedure for the correction of mitral regurgitation. If severe AS, send for TAVR or SAVR as discussed earlier. And consider cardiac synchronization if there is significant left or right bundle branch block. This is the latest ESC update on low BP in heart failure, reduced ejection fraction patients. I would like to focus on only one point. Patients with low BP, asymptomatic or only mild symptoms, do not down titrate or stop GDMT. That is the only thing that is in red there. The rest part I have discussed in short. My take home message would be no modification of GDMT in asymptomatic patients with BP 90, and this will improve the survival in these patients. Also concomitantly search for other causes and medication that affect BP, modify those to better drugs or other measures, correct the measures that we can continue with this GDMT for longer, for higher doses. Thank you.